Hello, I'm Dr. Jim Epstein, and this is Best of the Day from the 2013 combined meeting of ECHO, ESMO, and ESTRO held this year in Amsterdam of the Netherlands. So today we're going to be talking initially about gastrointestinal malignancies, specifically colorectal cancer. And joining me for this discussion is Dr. Axel Grothey from the Mayo Clinic, Rochester. Axel, welcome once again to Best of the Day.
Thanks for having me once again.
Well, thanks so much for coming, and I know it's been a busy meeting for everybody, but this has been an interesting meeting. There has been some interesting data regarding the management of rectal cancer and some very interesting data about molecular biomarkers in colorectal cancer, and are we doing enough to look at these and which markers really need to be examined before we plan therapy. So let's get right into it, and then we're also going to talk about FIRE3, which was a very interesting trial presented earlier this year. So the first thing is the TME trial, and this was an old trial with about 14 years of follow-up, looking at short-term preoperative radiation therapy and what kind of long-term effects on quality of life this had. So tell us a little bit about that trial.
So TME was actually a great trial run here in the Netherlands, and it actually served several purposes. They first of all trained all their colorectal surgeons in TME, which is total mesorectal excision, which was pioneered by actually a surgeon in England Dr. Heald, who actually went out about and said, this is the way you need to resect rectal cancers in order to minimize local recurrence. Because at that time we talked about the surgeon is the most important prognostic factor for local recurrence. So TME was a national endeavor. They trained all their colorectal surgeons. They trained pathologists to evaluate the specimen. And the trial randomized patients to optimize surgery with these trained physicians compared to radiation, short-course radiation, 5x5 gray, followed by TME surgery, to see whether in the context of optimal surgery, radiation therapy was still beneficial. And we have seen data to reduce local recurrence. Right. You couldn't expect any, let's say, impact on overall survival, but the New England Journal publication more than 10 years ago now, so that's how old the trial is, really confirmed, radiation therapy still, even in optimized surgery setting, reduces local recurrence, mainly for the mid and low rectal cancer. It's not a great effect on high rectal cancer. This is where we discuss the value of radiation therapy anyway. But the investigators actually also had patients on long-term follow-up. And this is quite remarkable. Normally when we talk about clinical trials, we reach the primary endpoint, and then we really don't care too much about following those patients. Right. But in this study here, again, a national endeavor, they were actually able to go back to those patients, and more than a third, more than 580 patients actually were able to complete questionnaires.
Yeah,
now,
that's amazing.
14 years after their treatment. And we learned a lot about, let's say, what are long-term effects of surgery, radiation therapy on, let's say, quality of life overall, which was not different between surgery versus the radiation arm. Sexual dysfunction, there was a difference. So patients who had radiation therapy, especially men, had problems to function sexually. And there were some more incontinence, urinary incontinence, etc. Pretty interesting data that we should not ignore when we subject our patients to a curative treatment option. I think we need to educate them that there are long-term side effects which will still be around 14 years later.
So still some bowel frequency and some incontinence in the patients who got irradiated.
And sexual dysfunction, yeah. The quality of life overall of these patients was not different between radiation and no radiation, but they also benchmarked it against the quality of life of the general population. Again, overall quality of life was not different, but the subtleties in terms of bowel function, etc., sexual function, was definitely in both arms, the rectal surgery and the radiation plus surgery arm, impaired compared to the normal population.
Well, the standard of care, of course, has changed with the German trial presented a number of years ago at ASCO with pre-op chemoradiation.
Correct.
Are the Germans following that population to see what quality of life has been maintained?
Not to my knowledge. I mean, you could probably go back to the patient population over time and try to re-questionnaire them, re-query them. And I actually think it would be worthwhile. I would actually expect similar outcomes, you know, because we were talking about radiation, chemotherapy, and of course, the impact of surgery overall on these health-related outcomes and patient-reported outcomes. I would think it would be very worthwhile. For me as a physician, right now, when I talk to my patient, these data raise a flag and say, you know, there's something we need to, when patient asks us, so what happens, you know, down the line, especially young patients, you know, if patients with rectal cancer are 30, 35 years old,
Right.
you know, they will live with the impact of what I subject them to for quite a long time.
So as I recall in that, it was an AIO trial, I think, it was pre-op chemoradiation versus post-op radiation.
The SOUR trial,
Right, so it'll be interesting to see, you know, whether the patients with pre-op chemoradiation actually had less problems long-term.
That'd be interesting. I mean, of course, there are several confounding factors. You had fewer rate of local recurrences in the pre-op setting, you know, which by itself can lower morbidity. And I like what the Dutch investigators did, benchmarking against the normal quality of life in the non-treated population, because you really need to see how both treatment arms actually affected patient-reported outcomes.
Very good.
I think this is one of those Dutch presentations. We saw a lot of Dutch presentations here in Amsterdam for whatever reason.
It seemed heavily weighted. All right, well, let's talk about FIRE 3. And this was a very interesting and very important and much needed trial comparing FOLFIRI-cetuximab versus FOLFIRI-bevacizumab in patients who were KRAS exon 2 wild type. So
I like that you say that. I like that you say that. I mean,
tell us a little bit more about that trial, what the results were that were presented earlier, and what this update concerns.
So actually, I like to kind of put this into perspective of the recent New England Journal publication by Jean-Yves Douillard, who actually analyzed the PRIME trial. So we're talking about first-line therapy in colorectal cancer, metastatic colorectal cancer, defining the role of EGF receptor antibodies. In PRIME, it was FOLFOX plus minus panitumumab, and in FIRE 3, a German-Austrian trial, about 600 patients enrolled. It was, as you said, a comparison between bevacizumab and cetuximab added to FOLFIRI in conventionally defined KRAS wild-type tumors. So when we normally send out tests right now for KRAS wild-type, we send out a test and we're looking for mutations in codon 12 and 13. And the PRIME analysis, or the reanalysis of the PRIME data published in New England Journal of Medicine actually just about 2 weeks ago, went further, went beyond just the conventional definition of KRAS wild-type. Because there are mutations in other exons, exon 3, exon 4 of KRAS, and there's NRAS, which is a RAS molecule. It's just not covered by our conventional mutation analysis. So you have mutations exon 2, 3, and 4 of NRAS. There's HRAS, actually, which we normally ignore because it really doesn't play a lot of role in colon cancer. So the PRIME investigators, and this sparked the interest in additional RAS analysis, presented at ASCO and now published in New England Journal of Medicine, that they can identify another 17% of patients that have low-frequency KRAS mutations in exon 3 and 4 and NRAS mutations, in addition to the 40% that we normally consider KRAS mutated. So there are about 57, 60% of patients that have any form of RAS mutation. And the New England Journal analysis showed that those patients who had any RAS mutation, even beyond the conventional KRAS mutation, they didn't have benefit from panitumumab added to FOLFOX. In fact, when they were treated, they had a detrimental effect. So when they were excluded, a refined patient population, now you saw a nice overall survival benefit actually for the addition of panitumumab to FOLFOX, with a hazard ratio of 0.78. Yeah, that's
not bad.
It's not bad for overall survival, 22% reduction of death events. But if you treated the wrong patient population that had the 17% of patients that we normally don't identify, they actually had a detrimental effect, hazard ratio of 1.29, a 29% increase in death rates. So
it's really important.
Yes.
Just knowing that their KRAS wild type codon 12 and 13 is not enough.
Not enough anymore. And actually in Europe, the label for panitumumab has been changed.
Right, I recall
You need to test for all RAS mutation. Now, that's our challenge right now in the United States. We'll probably need a clear certified FDA compendium diagnostic certified test in order for us to really have a label change in the end. But it shouldn't prevent us from looking at it in clinical practice. I mean, there are laboratories out there that look for KRAS, or extended KRAS, NRAS mutation. Now, coming back to FIRE3, FIRE3 was presented, the initial analysis was presented at ASCO 2013. We talked about this before. Surprising results, no real big difference in response rate, 58, 62%, which was the primary endpoint of the study. So cetuximab, bevacizumab added to FOLFIRI, similar response rates, no difference in progression-free survival, 10 months, 10.3 months. But there was a difference in overall survival. And initially, the difference was about 3.7 months in favor of cetuximab compared to bevacizumab. And the curve split after about 2 years. So way after the initial treatment phase. So we all puzzled and wondered, why would that happen? Were there imbalances in, let's say, later lines of therapy? The ESMO GI meeting in Barcelona, another update was presented. There were really no discernible differences in second and third line therapies, at least not numerically. And then here, they presented the all RAS wild type update, which was sparked by the PRIME analysis, New England Journal paper. And the results were quite interesting because for the selected patients, now all RAS wild type, elimination of the KRAS mutation, exon 2, 3, 4, NRAS mutation, now patients had, again, perhaps a little bit more response rate, so refined, not a lot more progression-free survival, but now median overall survival of 33.1 months.
Right.
Longer, clearly longer than the bevacizumab group. Hazard ratio went down to 0.7, which was strong for overall survival. And the patients who had any RAS mutation, those additional mutations which had been not identified before, they actually had definitely lower response rate, lower and shorter progression-free survival, and clearly shorter overall survival compared to the all RAS wild-type patient. And actually also it seemed to be a trend toward lower outcomes and inferior outcomes to bevacizumab. So bottom line is we need to test for more than just the standard KRAS.
Well, we know that from some of the adjuvant studies that bevacizumab seems to have an effect until you stop it.
Yep.
And then that effect fairly rapidly goes away. Perhaps the effect of anti-EGFR monoclonal antibodies is more durable.
Yeah, it's an interesting question because what I'd really like to see, I mean, we are now looking at all RAS wild type and strong data for cetuximab and actually also for panitumumab, now FOLFOX base or FOLFIRI base. The comparator should actually be a treatment effect of optimal duration of anti-VEGF therapy. We've talked before about induction maintenance therapy strategies, Cairo-3, for instance, treatment across multiple lines, the bevacizumab beyond progression. So would you still see a difference if you optimize the first, second line use of bevacizumab, for instance, an anti-VEGF antibody, compared to early use of cetuximab? So I think now, and this came up in discussions, I think, very elegant discussions actually when we talked about how do we make sense of these data for clinical practice. What are the trials we need to run? We need to really investigate the strategy. Is it important to start in all RAS wild type, start with EGF receptor antibodies, use anti-VEGF therapy for second, third line? Or can we have the same result or a similar result or even better result if we use anti-VEGF therapy up front and use EGF receptor antibodies in this refined patient population later line? a lot of questions to be answered.
Absolutely. Well, speaking of panitumumab and cetuximab, the ASPECT trial was also presented. And this was a non-inferiority trial trying to determine whether cetuximab and panitumumab are equally effective. And these were patients who had relapsed. So this was monotherapy with an anti-EGFR antibody. We know from a lot of prior studies that cetuximab has single-agent activity, 10-12% response rates, and you add it to irinotecan, and it's even better. How did panitumumab compare?
Actually, it's interesting because when you look at the pivotal trials that led to the approval of cetuximab and panitumumab, the cetuximab trial did not allow crossover, so they had an overall survival benefit. The panitumumab trial did allow crossover. More than 70% of patients did crossover, so they had a similarly strong PFS benefit as cetuximab, but no overall survival benefit. So regulatory agencies actually mandated that this trial head-to-head comparison should be conducted. And these antibodies, I mean, what we had expected, that they are more or less equivalent. They were equivalent in outcome, overall survival outcome. There were perhaps minor differences in toxicity profile, more infusion reactions with cetuximab, more hypomagnesemia with panitumumab. But virtually, I mean, it was actually a very well conducted trial in terms of a non-inferiority trial, which are not easy to conduct in general because you need a large sample size. That is about a 1,000 patient trial across the world. So this was a huge commitment, and for all practical purpose, and this is validated now, panitumumab and cetuximab have the same clinical efficacy.
Very good. Let's move on and talk about prognostication in stage 2 and 3 colon cancer, an early disease. Who needs chemotherapy? Who doesn't? Oncotype DX for colon cancer has been around now for several years and seems prognostic in stage 2, but not predictive.
Correct.
But do the same results work with rectal cancer? Frequently managed differently. We know it's prognostic in colon cancer. Investigators at this meeting presented the data regarding rectal cancer. And then comment a little bit about these gene expression profiles in general as to where you think they should be used, where you're using them in your practice at the Mayo Clinic.
Yeah. So I mean, so there are several points for that. We have talked a lot about molecular signatures, prognostic markers in colon cancer. Rectal cancer is a more complicated disease because you have a lot of neoadjuvant therapy, the concept of radiation, the quality of the surgery that plays into a role to really determine outcomes. So there are a lot of factors that really play a role in the eventual readout in when you do a study, when you analyze, for instance, the validity of a prognostic marker test. So the Oncotype DX investigators actually went to the Dutch TME trial again that we already talked about, and they collected information. They want to see whether their tests held up with the 18-gene panel in rectal cancer too, the same test they have in colon cancer. And they looked at the surgery alone arm, so no radiation therapy to get one of the factors out of the equation. And they asked the very important question, can we identify a low, medium, intermediate, and high risk group in rectal cancer, which might warrant different treatment strategies? Because one of the concerns we have in rectal cancer is also over-treatment.
Right.
We actually running a trial right now in the United States, led by Deb Schrag, an intergroup effort to see whether in patients with, let's say, mid to higher rectal cancer, even lymph node positive, we can eliminate radiation therapy because of the long-term using chemotherapy alone. And it would be nice if we could actually expand this, let's say, pulling away from the long-term toxicities but not harming patients by jeopardizing their outcomes in rectal cancer. I mean, there are even data coming out of Brazil, Habergama, a surgeon and a radiation oncologist in Sao Paulo talks about we don't need surgery anymore if we have a complete response after radiochemotherapy. So there's clearly not validated prospective trials, and we should just put this out there as something that is being discussed, pulling away from the toxicities, acute and later toxicities of our treatment option.
Right.
Now
Sounds like he's trying to manage it the way squamous cell carcinoma of the anus is
exactly,
managed.
and at some point, when we talked about anal cancer in early 1980s, that's how long this concept has been around. We pulled away from kind of mutilating surgeries, APRs. Now, the Oncotype DX gene expression panel was tested, and they were able to identify a low, intermediate, and high risk group, which actually spread out quite nicely in these stage 2 more than stage 3 cancers. So I think it's similar to what we've seen in colon cancer. You can separate these patients out in terms of disease-free survival, for instance. Now, whether this will be integrated, let's say, in future trials, stratification for clinical trials, whether this will be used eventually in clinical practice, I think we need a little bit more data on that.
Right.
And this is true for a lot of these gene expression panels. We talk about Coloprint, we talk about GCC assay, not just in various other assays that are out there, spearheaded by European and American investigators, that companies popping up that have molecular profiling tests available. All these tests, I think, are not yet ready to be consistently used in clinical practice.
Right.
And at Mayo Clinic, if you ask me, so what do I do? I still rely at this point in time on clinical staging, meaning TMN classification, MRI in rectal cancer or endoscopic ultrasound with biopsies. We do test for MSI high, microsatellite instability, which is a strong prognostic factor. So these are the criteria we use. And for standard use, in clinical practice, I don't think any of these gene expression profile tests are yet ready for prime time.
How common is MMR deficiency in rectal cancer? You usually think of that as a right-sided colon.
Yes, it is. It's clearly, the right-sided colon in stage 2, about 20%, and the further you go to the anus, the lower frequency you have goes down to about less than 5%. But if you have a young patient with a rectal cancer, this patient could still be a member of an HMPCC family.
So if they're MMR deficient, would you not use 5-FU?
A very good question. Those are those patients we would consider chemo-resistant to 5-FU. No one has ever tested this in the context of radiation therapy, because we're using 5-FU more as a radiation sensitizer. Would we use 5-FU as adjuvant therapy? I would not. But if a patient had lymph node positive disease, I would use an oxaliplatin 5-FU regimen. And we have data from Mosaic, at least extrapolated for colon cancer, that patients with stage 3 mismatch repair deficient tumors, microsatellite high tumors, they benefit from FOLFOX to the same extent as proficient tumors.
Very good. Well, let's move on to one of your favorite trials, the CORRECT trial. So you were heavily involved. You were heavily involved in that trial, and we all know that there's a statistically significant improvement in progression-free survival and overall survival with regorafenib in heavily pretreated patients that led to its approval, even though in the progression-free survival curve there was this separation after a while, suggesting there's a subset that is more sensitive, as yet to be identified. But the question with many of these small molecule targeted inhibitors is the adverse event profile. And so quality of life was looked at in the CORRECT trial using various QOL instruments. So tell us about this effort. What the investigators decided as they compared quality of life, and what your experience has been as far as the quality of life in your patients who have been treated with regorafenib.
So every time we have a new drug that has side effects, which every drug has, that we use cancer therapy, I think it's fair to see how it impacts patients' quality of life. Now, it is probably, and this comes back to the specifics of the CORRECT study, eventually you can make an argument, okay, in a patient population with an unmet need, backed against the wall, you're one step away from having no treatment option at all anymore, and you have the hospice care discussion.
Right.
In the correct study, patients were willing to tolerate side effects because they wanted to live. So this throws a little bit bias into any quality of life analysis. Even though it was a blinded study, patients who had discernible side effects knew they were on the drug. You know, if you have a rash,
Breakout in a rash.
breakout of a rash after 2 weeks of regorafenib, you know you're not on placebo. So that is the problem with all these quality of life analysis, in particular in the last line setting. The analysis with using two different instruments, a cancer-specific and ERTC quality of life QLQ 30 C30 instrument, didn't show difference in quality of life. There was really no difference between patients on placebo versus regorafenib. You could interpret this in a way it doesn't harm to use it. It doesn't improve quality of life because this drug does not take tumor symptoms away necessarily because it doesn't shrink tumors. It stabilizes what you have, so you're happy to get away with what you had before. Now the problem is when you do the analysis, the quality of life analysis hardly ever adjusted for how many patients were actually alive to fill out these questionnaires at any given time point. When you look at the quality of life time flow over time, because patients were asked repeatedly in the course of the therapy, at any given time point, there was a lot more patients who were able to fill out the questionnaire on regorafenib than who were able to fill out the questionnaire on placebo. Actually, the end of the curve, and this is one of the perhaps criticism to the presentation, the last 5 time points, the placebo arm had only 1 patient.
So quantity of life was even more impressive than quality of life.
Yeah, in some ways, yes. Those patients, coming back to what you rightfully mentioned, you know, that the progression-free survival curves split kind of at a certain distinct time point. If you didn't have a progression at 8 weeks, when the first scan was done, you had a pretty good chance to benefit from the drug. So that is kind of it's not a good biomarker, but it's an imaging marker. And you say, you know, worst case scenario, if you talk about ineffective toxic therapy, patients endure this for a total of 8 weeks. You know, 3 weeks on, 1 week off, 3 weeks on, 1 week off. And then we know, and if patients are in the good category, you know, the benefit, they sometimes have long-term benefit. So it's not easy to really do well, valid quality of life assessment, particularly in a last line setting. It's always a little bit of a bias. Just as a side note, I remember Kathy Eng presenting the data of the Crystal trial in the quality of life analysis. And we know that the addition of cetuximab to FOLFIRI adds about 5 to 10% of grade 3-4 diarrhea. That is a known fact. I mean, EGF receptor antibodies, alatinib too, add diarrhea. But when the subgroup, in the subpart of the questionnaire, the quality of life of associated to diarrhea was actually better on the cetuximab arm. So patients had more diarrhea, but they were a lot happier about it because they had a rash.
Yeah.
They knew they were on the drug.
They knew they were responding, yeah. That's interesting. Well, we always think of cancer as being a disease of the elderly. Median age of diagnosis of like breast cancer, lung cancer, prostate cancer is in the mid-60s or so. But some people still get cancer when they're young, and it's always a heartbreaking thing when a young mom or young dad gets cancer. But is cancer in younger people worse than when you get it when you're my age? or for me, it would be worse. But there was a study, this ARCAD clinical trials program looked at their younger patients who developed colorectal cancer. And how did that group compare with the older group who developed the same problem? Were they better cancers or worse cancers? Did they present at a better stage or a worse stage? What did they find, and what did they conclude, and what do you conclude?
So the ARCAD effort is actually combining the individual patient data of, I mean, really virtually every single phase 3 trial run in first, second, third line therapy. That's the effort we're trying to put into. And just as full disclosure, I'm part of the ARCAD group. So the presentation at ESMO, ECHO, Astro here by Chris Liu was about an analysis of about 20,000 patient pooled information of patient data and separating out the outcomes for younger and older patients, actually giving a kind of looking at age as a continuous variable, which it is. Because you don't want to group patients, who are 20 with patients who are 40. There might be differences in biology. That's a question we've always asked. So younger patients, do they have a difference in biology? Keeping in mind that even in young patients, a minority of these cancers, colon cancers, is based on HNPCC, FAP familial syndromes. So when you look at the low frequency of cancer, colorectal cancers in younger patients under 50, 40, and the fact that it highlights the fact that we need a large database. So the analysis that Chris presented on behalf of ARCAD showed that patients who are diagnosed with at a very young age, and the younger they were, they actually had poor outcome in terms of all parameters, progression-free survival and overall survival in this palliative setting. And there was actually the best outcome for patients was interestingly in the late 50s, early 60s. That's where the curve actually dipped in terms of, they had the best outcome in progression-free survival and overall survival. Now, there are several confounding factors here. And the one thing that was kind of mentioned in the presentation, which I think is critical to keep in mind, when patients have symptoms, if a 20-year-old comes to me with bowel problems and changes in bowel movements, whatever, or even blood in bowel movements, I probably more suspect inflammatory bowel disease or hemorrhoids or whatever. I don't necessarily think of colorectal cancer right away. So the workup, endoscopy, imaging scans could be delayed. So this analysis was not adjusted for tumor burden. So we have data from other studies, from more controlled and not pooled studies, that if it's stage adjusted, young patients and older patients have the same outcome if they were treated in the same way. And that is the problem. So I would caution a little bit over-interpreting the data in terms of, young patients have a bad biology of their cancer. It could be just a tumor burden bias, delayed diagnosis. What's reassuring and actually what makes sense is that older age is eventually leads to poorer outcome because our treatment intensity, lines of therapy, comorbidities, influence progression-free survival, overall survival. And at least as someone who's not at this age yet, reassuringly, early 60s is a pretty good time to have colorectal cancer because that's where your outcomes are probably best.
Very good. Yeah, I agree. I think we've all seen younger people come into the office with low rectal cancers who have been bleeding for 6 to 9 months and before anyone really looked into it.
Very standard.
Yeah. So we've already talked quite a bit about KRAS mutations and NRAS mutations and BRAF and all that, so I don't think we need to go any further on that. The only other mutation that we really haven't talked about was the PIK3CA mutations and that whole signaling pathway of PI3 kinase, AKT, and mTOR. And there was an amazing presentation at this meeting that was initially, the trial was designed to look at the value of rofecoxib as a preventative agent, what we used to call Vioxx in this country, in the U.S., that eventually got eliminated because of its cardiac activities, to see whether or not rofecoxib was related to PIK3CA mutations and whether that had a benefit. So tell us about some of the interesting findings in that study.
Yeah, so this ties again back to a New England Journal paper about a year ago, where international investigators, including the group of Charlie Fuchs' group at Dana-Farber, looked at the impact of use of aspirin in patients who had a resected colon cancer. And in this analysis, in this New England Journal paper, they correlated the known, and we've talked about this before, protective effect of aspirin to mutations in PIK3CA. Not COX-2 overexpression. Aspirin is a COX-1 and COX-2 inhibitor and probably does even more in terms of as a molecularly targeted agent than what we think, it's probably something beyond COX-1 and COX-2. So they initially published data which were quite amazing, that patients who took aspirin after colon cancer resection had a reduction in disease recurrence with a hazard ratio of 0.18. So an 82% reduction.
Best cancer drug there is.
Best cancer drug there is. I mean, the question that they, of course, now we have, this is not randomized data. This is kind of retrospective analysis, observational data. There was no randomization plus minus aspirin. And now the question is, do we have confirmatory data? Can we have a data set that is very similar? And can we make sense of it? Is the effect that we might see in the same degree, the same magnitude?
Which group is going to get the biggest benefit?
Exactly. So the Victor trial, that was the Vioxx rofecoxib in colorectal cancer trial. It was a initially large trial until rofecoxib was pulled to see whether rofecoxib could be a protective agent in patients who had resected early stage colon cancer. And they correlated with mutation analysis, COX-2 analysis, whatever. So what they presented here at the meeting, which was actually already published in JCO last week as an early release, was that very similar in patients who had who took rofecoxib or not had no benefit, but they only took rofecoxib for about 9 months. But when they asked about aspirin, whether they used aspirin or not, again, patients who took aspirin had a risk reduction of recurrence of about 90%.
Because of the worrisome combination of aspirin and rofecoxib, they were restricted to 100 milligrams or less.
Absolutely, and that's a very interesting point. So patients were allowed to take aspirin less than 100 milligrams, or equal to or less than 100 milligrams, which is more or less the baby aspirin, 81 milligrams that people take for cardiovascular prevention. So in patients with PIK3CA mutations, 12% of patients had colon cancer with PIK3CA mutation. The hazard ratio for recurrence when they took aspirin was 0.11.
Right.
Actually, the disease-free survival curve was no patient had a recurrence. It was a complete flat line at 100%.
If they had a PIK3CA mutation
If they took aspirin.
They just kept going.
I mean,
that's amazing.
That was pretty amazing. And Alberto Sobrero, who discussed this now, talked about, can we run a prospective trial randomizing patients with PIK3CA mutation to aspirin or not? And in all honesty, it's hard to. If I told you,
so many people take aspirin.
If I told you too, you had a colon cancer, or any patient resected colon cancer, we do mutational analysis, PIK3CA mutation. Would you now inform me about the results of what we've seen? No recurrence at all in one study, even though it was not powered and low numbers, whatever. You probably go to your store next door and to Walgreens and pick up this huge bottle of 81 milligram of aspirin.
A lifetime supply.
And I cannot prevent you from doing it.
Absolutely.
So I
Absolutely.
don't think it's really feasible to prospectively test it. Do you take aspirin?
I don't.
I do.
I don't. I take ibuprofen, but I don't take aspirin.
It might not work.
Yeah, it might not. But I'm still here.
But it's interesting, and there was actually a whole session at ESMO ECHO devoted to aspirin. Aspirin, the wonder drug in oncology.
Yeah.
So it's very difficult to prospectively test it, but the accumulated evidence really suggests it is, it really has a strong, at least in colorectal cancer, a strong secondary prevention effect.
One more reason to get your baby aspirin. I'll have to start. Well, Axel, it's always great getting together with you and talking about colorectal cancer and other GI malignancies. You always have a wonderful perspective on the data, and I think it's very helpful for all of our viewers, so I appreciate you coming by.
Thanks for having me.
All right, you bet. And thanks to all of you for watching this segment of Best of the Day from the 2013 combined ECHO-ESMO Astro meeting in Amsterdam. I hope you will check our website for additional programs. Thanks so much.